You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites in iTunes, and you can also follow us on Twitter at ASAM.org and Facebook. Now, let's go beyond the abstract.
Welcome to Addiction Medicine Beyond the Abstract. I'm your host, Dr. Sean McNeil, and today we're joined by Dr. Michael Incze. Dr. Incze is a primary care and addiction physician and a clinical associate professor at the University of Utah. His article in the November-December issue of the Journal of Addiction Medicine is titled Expert Panel Consensus on the Effectiveness and Implementation of Models to Support Post-Hospitalization Care Transitions for People with Substance Use Disorders. Dr. Incze, thank you so much for joining us. This is your second appearance on the podcast, so I really want to thank you for being here. For those listeners who missed your first episode, could you talk to us a little bit about how you got involved in treating addiction and what course your career took?
I, really came to be interested in research around substance use disorders just by what I see in clinical practice. I'm sort of a primary care clinician first and foremost, and so the last time I was able to join you, we talked about some primary care-based research I'd done, but I think, increasingly I've been interested in care transitions. We are on the receiving end in primary care-based addiction medicine of care transitions from a number of acute care settings like the hospital, the emergency room, in addition to referrals from elsewhere around our health system. And I just have been so sort of impressed with the incredible amount of things that have to go right for a care transition to be successful. And just the amazing amount of, individuals, the patient first and foremost, but then across different care settings that sort of have to coordinate and work in harmony for a good care transition. It's not a given or an easy thing, and they oftentimes don't go well. So I think, I'm interested more and more in researching how to make those better, and I think to, sort of get started on that process, and really what the topic of the research we're going to be discussing today is just to sort of identify, what models may hold the most promise. What are people working on around the country as they address these problems in their own health systems and clinics, and which one of those models seem to be perhaps the most feasible and the most effective to inform further research and program development.
All right, very good. So I want to turn to the subject of this article. We'll be looking at post-hospitalization care transitions. And my first question is, was there something that you noticed, perhaps clinically in your own practice, that led you to want to study these transitions a little more closely?
Yeah, like I was saying, I feel like I run a multidisciplinary, or I should say I co-run a multidisciplinary primary care-based, addiction medicine clinic where we provide integrated substance use disorder treatment and primary care to patients, and we receive transfers of care from acute care settings like the hospital and the emergency department, et cetera, every week. I feel so fortunate to work with this fantastic interdisciplinary team that we've sort of built from the ground up here at the University of Utah, and every single person on our team, right? Our peer support specialist, our nurse lead, our social worker, our clinicians, our medical assistants, they all play such key roles in helping our patients establish care with us. And when things don't go right, we provide outreach, we find folks, and we really try our best to loop them into care. It made me think, wow, we've sort of built this model here, but I'm sure elsewhere around the country, people have been faced with similar challenges and have really invested in their own unique models, many of which have been studied, at least in small trials. And so, over the last couple of years, I've really tried to do some work characterizing the different types of interventions that have been tried across the country. We did a narrative review on that last year. And then, once you've kind of identified what's out there in the country, what innovative folks are doing in practice, the next sort of step is figuring out, well, is there a way to create a hierarchy of these models, according to which ones may be most effective and which ones may be most implementable. And I think the research, the clinical research is still nascent in this area, so we don't have huge RCTs to guide practice. But what we do have is a lot of experts who've tried a lot of these models, and that's really what led us to do this expert, modified Delphi panel to try and get folks with the experience across, disciplines and the care transition spectrum to weigh in on what models they've seen and which they feel like are most promising.
Well, very good. And, it sounds like studying these models in a formal way will help clinicians in a variety of settings. Now, looking at your article specifically, you described the creation of these ACT teams, ACT. Now, as a psychiatrist, I'm familiar with ACT in standing for Assertive Community Treatment. However, the ACT team you speak of stands for Addiction Consult Team, which is a quite different thing. So can you explain what an ACT team is and how it's composed?
Yeah, absolutely. And we were aware of the overlap with the Assertive Community Treatment and sort of went with the ACT acronym anyway. But you're right. This is distinct model from those community-based models. These are inpatient addiction specialty teams, and there's so much diversity in how these teams are constructed and operated around the country. And it just feels like there's so many innovators around the country who are continually improving care delivered through addiction consult teams that I feel like it's an evolving science, right, and an evolving area of clinical practice innovation. But in their essence, they're inpatient teams that usually have some kind of addiction specialty clinician surrounded by other disciplines, including, nursing, physician's associates, social workers, peer navigators, and various sort of permutations. And their goal is to provide access to addiction specialty care to any hospitalized patient, kind of on a consultation model, to really help with diagnosis and treatment initiation and other key tenets of substance use disorder treatment, like harm reduction, while patients are hospitalized for any reason, right? It doesn't have to be related to a substance use disorder. But we know that hospitalizations are really common amongst people with substance use disorders. And Leslie Swen and her group did a study that estimated that 1 in 9 hospitalized patients has a substance use disorder. So addiction consult teams really are there to meet that need, to meet those patients in the hospital, offer treatment, engage them, and then increasingly offer assistance with transitions to community care once they leave the hospital. And while ACTs are sort of inherently an inpatient intervention, we sort of, for our study, we sort of divided them into ones that, strictly operate within the hospital and this kind of notion of a continuity enhanced addiction consult team where there's a core component that works in the hospital, but then they may have partnering clinics that they work with on the outpatient side, or, peers that sort of work inpatient and outpatient to help the patient once they leave the hospital transition to community care. And we sort of thought that was a distinct and exciting sort of emerging model within the existing ACT model.
All right, great. Now, when you and I spoke previously about your study, we talked about the interdisciplinary nature of these ACT teams. I specifically wanted to hone in on the role of nurses. Can you speak to the role that nurses played on the ACT teams and how they impacted patient care?
Yeah, well, I think nurses kind of do it all. And especially in the substance use disorder space, we've seen so many instances in which they've led outpatient clinical operations and led inpatient clinical operations and just have such a unique lens onto the care of the patients. So they sort of are embedded in several of our models that we did in this Delphi study, right? We have, for example, models that just uniquely are sort of transitional care management models, which are oftentimes nurse-led. We have like expert models, which in many of the studies where those have been evaluated have been nurse-led. We have partnering outpatient clinics providing InReach, which is sort of like an outpatient intervention where clinics reach into the hospital to meet patients while they're hospitalized and facilitate care transitions. Those are oftentimes nurse-led. And then certainly the addiction consult teams. Nurses are integral pieces of those clinical teams. And I think while they do so much across the sort of spectrum of substance use disorder care, I think one of the key components is really facilitating that like care transition part, right? Like identifying barriers that and anticipating barriers that patients might face after discharge, talking to patients, collaborating with them, and communicating with them in ways that are mutually understandable, troubleshooting, and really helping that patient get to where they need to go once they leave the hospital, which is, ideally continuity of substance use disorder treatment if they desire that, and also medical care, right? These hospitalizations are medical hospitalizations, meaning that, substance use disorder treatment is only part of the follow-up. Usually there's a medical follow-up plan too, which just adds like another layer of complexity, I think, and having that nursing expertise, I think, is key, and that's why nurses are literally part of most, if not all, of the models that we evaluated in our Delphi study. And you said it right, Sean, this interdisciplinary team structures are probably like the one commonality, the most common feature of all of the models that we identified was that, it takes a village. It's not just about one discipline. It's about leveraging expertise of multiple different disciplines, really with the patient's voice at the center of it all.
Right. And especially, considering how complex substance use is and how it involves a range of psychosocial factors and a multitude of team members across disciplines to engage these patients. Now, I did want to bring up the concept of lived experience. There are several substance use treatment programs that focus on peer support, including those individuals with lived experiences, those that have had substance use problems in the past, and including them in the treatment process. However, those with lived experiences were not a major consideration in this study. Can you comment on that a little bit?
Yeah, absolutely. That is such a good question. And if I could go back and do the study again, that is like the one thing, like number one on the list of things I would do differently. And, to clarify, we definitely didn't exclude people with lived experience in the study. But what we didn't do is actively recruit them. So it is very possible that amongst the people who participated in our panel, there were folks with lived or living experience. We didn't ask about that, and so we don't know. The rationale when we were designing this expert panel was that the models that we presented to people are all a little technical in terms of, there's a lot of healthcare and care transition sort of jargon. For example, just post-discharge outreach is the name of one of these models, or addiction consult teams. And we thought that it would be helpful to have some clinical training to interpret these and sort of give an expert opinion on them. However, certainly having lived or living experience and being a clinical expert are not mutually exclusive. And I do think that it's a significant limitation of this study that we didn't explicitly recruit people with lived or living experience to participate in the panel. And as you said, I think, this study tells us what it tells us, right? It tells us the perspective of a vast range of clinical disciplines on care transition models. But it does not tell us, I think, in a robust way, how people with lived or living experiences with care transitions and or substance use really would perceive these care transitions. And I think you could easily redo this study, specifically focusing on having folks with lived or living experience evaluate these models. I will say a huge focus of the work myself and my colleagues are doing right now is really, having folks with lived or living experience lead our research, as partners and as leaders in designing this study. So I feel like your point is well taken, and it's really informed the future directions and sort of what we're up to now in terms of evaluating interventions to improve care transitions.
Okay, good. And, when we spoke earlier, we talked about clinical pearls and how this study may be useful to clinicians. Your paper did interestingly find that all models that you studied were better than the status quo. Can you comment on that trend?
Right, absolutely. So we asked our panelists to rate each of these 10 models according to 6 criteria that were based on the GRADE evidence to decision framework. 3 of them were like effectiveness criteria. Like how do you think this model would affect linkage to care, retention and treatment, and remission from substance use, as compared to like whatever you're doing now, right? The status quo where you work. And then we had 3 implementation criteria too, which were acceptability, feasibility, and impacts on equitable access to treatment. And as you said, we found all 10 of the models ranked as good or better than what was currently happening at the person's current institution, right? Which is, I guess, not that surprising because a lot of places don't have a formal model, and so I think people hear about these different interventions and are like, yeah, I would try that. That sounds great. These are all interventions that have a precedent, right? We took these from a narrative review that we did, like I said, last year, and so these have been tried and in many cases evaluated. So I wasn't that surprised that people found them in general to be more effective than the status quo. I will say, one of the most interesting things about the panel is that even though people found these to be effective, there was a lot of sort of shift in opinions, and I really attribute that to the sort of interdisciplinary nature of this panel, right? So the way we did the study is we had everybody rank these models according to the 6 criteria I mentioned, and then we held this kind of asynchronous discussion board where everyone could sort of, talk about their answers and how their answers compared to the group medians. And the discussion was robust. We got pages and pages and pages of transcripted qualitative data, much of which is actually included in the article in an appendix. That is just fascinating. And I think what we learned from that is that, talking to people across disciplines and across the sort of care transition spectrum, right? Like inpatient providers talking to outpatient providers about these different models really changed opinions. In fact, in 5 out of our 6 rating categories, over 50% of the ratings changed from round 1 to round 3. So to me, my takeaway from that is that, if you're thinking about designing a care transition model, you really need to have like all the stakeholders at the table. People with lived and living experience, absolutely. But then also, the care managers, the pharmacists, the hospital clinicians, the outpatient clinicians, because, talking through your ideas with them is really going to teach you, help you anticipate things that you might not otherwise think of, because we all kind of work in our silos, right? In our care environments. So that was a big take home for me. But even despite these sort of conversations and changing opinions, people still didn't lose their enthusiasm for all these different models.
All right. Well, those were all great points. And assembling a multidisciplinary team can be tough, and you want to make sure that there isn't any oversight. However, it's nice to be as inclusive as possible and have all of the stakeholders at the table.
I was just going to make the point that the thing that changed the most, the category that changed the most, was feasibility by quite a ways, actually. And I think to your point, it just says that, talking to people who are going to implement other parts of this care transition model really helped people understand some of the challenges in implementation that ended up affecting their opinions about the feasibility of these different models. But it didn't make them seem infeasible. So I really do believe that, there are models that any health system can implement. And one thing that our study does that I haven't mentioned yet, but it's worth checking out if you're listening to this podcast and want to read the article, is we do sort of create this matrix of all 10 models based on their implementation scores and their effectiveness scores. And so you can sort of see what models had the best combination of implementation and effectiveness. And those would, I think, be the ones where we would identify as here are the ones that we want to study, right? That we want to invest in doing some clinical research on these models based on expert consensus. So exciting next steps for this work.
Yeah. And, that kind of leads into my last question, which is, the fact that these addiction consult teams and bridge clinics are big undertakings. And depending on the community and what resources are available, may or may not be feasible in some locations. So aside from the personnel, is there any other big consideration that needs to be made when implementing one of these models?
I think the thing to consider is that there's something for everybody, right? So, for example, in this study, I think really helps to illustrate that in the sense that there were a bunch of models that maybe were not rated as high in terms of effectiveness, but were rated highly in terms of implementation. For example, developing a protocol for your inpatient teams to follow in terms of like medication initiation or providing discharge resources, or developing a relationship with a community peer support specialist network. Those things certainly are simpler and more feasible, I think, than developing an addiction consult team. And I think the message is that there's always something to do, right? That is likely to be better than the status quo. And so one other thing I think that this article does is really sort of give health systems and clinicians who are looking to try and build something to improve care transitions where they work, kind of like a menu of options that they can say, that they then can have read these sort of expert opinions on in a fairly granular way with our 6 rating criteria and our qualitative data that we included with the study as well, and make decisions about what makes the most sense for their health systems. So it's not just addiction consult team or nothing, right? There's 8 other models that we evaluated. So we really hope that there's something here for all health systems and all clinicians, regardless of sort of where they're at in terms of resources and building their clinical team.
Very good. Well, thank you so much, Dr. Ince, for joining us on the podcast for a second time. Dr. Ince's article can be found in the November-December issue of the Journal of Addiction Medicine.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.